Good afternoon. My name is Carlos Rivera, and I'm a research fellow at the Cleveland Clinic, Florida. Before I start, I would like to thank the Society of American Gastrointestinal and Endoscopic Surgeons for this opportunity, and to my mentors, Dr. Rosenthal, Dr. Lomenzo, and Dr. Schoenstein. Today, I will be presenting improvement of glucose metabolism after bariatric surgery, reduction of visceral abdominal fat versus free fat muscle. The authors declare they have nothing to disclose. Body fat distribution is highly associated with metabolic disturbances. During the last 2 decades, substantial progress has been made toward the mechanism and involvement of ectopic fat deposits and its association with metabolic disturbances, particularly large fat deposits like the visceral fat. Its proximity to organs that have central functions such as the liver and pancreas, because they are considered to have influence on the body's metabolism as well as surrogate markers of inflammation. Skeletal muscle may play an important role in glucose metabolism as it serves as an important organ for glucose storage. Visceral fat and muscle mass are known to be interrelated from a pathogenic point of view and are reported to share common inflammatory pathways. These markers of inflammation, due to the accumulation of ectopic visceral fat deposit, may contribute to the development of sarcopenia. Over the past years, it has been elucidated that under lean, healthy conditions, there is a favorable immune metabolic pathway that is capable of maintaining healthy adipose tissue and skeletal muscle status. In obese patients, adipocytes undergo hypertrophy and hyperplasia, activating the immune system inflammation pathway over the muscle tissue. This shifts the balance towards an unfavorable state that results in a decrease of quantity and quality of muscle tissue. Therefore, it is hypothesized that obesity and sarcopenia are associated and may act synergistically, having an impact in metabolic and cardiovascular disorders. Low muscle mass is being associated with metabolic syndrome, type 2 diabetes, and a decreased survival. That is why it may seem important to study the repercussion of rapid weight loss following bariatric surgery and the effects over skeletal muscle tissue, as in the common practice, they are poorly documented. We conducted a retrospective study in patients who underwent bariatric surgery between the years 2011 to 2017 in our institution. Patients were eligible for inclusion if, besides having a BMI over 30, they had documented type 2 diabetes with installed treatment. In those patients, we measured the abdominal CT scan, the visceral volume, and the skeletal muscle area. Then we calculated the free fat mass using a previously validated formula before procedure and a 12-month average follow-up. 25 patients met our selection criteria. 80 of them were females and 68 were white with a mean age of 52 years old. In this table, we can observe a group of patients with an elevated BMI and a control level of glucose and A1C previous to the procedure. Our result after bariatric surgery shows statistically significant decrease in BMI and visceral fat storage, as well as biochemical markers such as glucose, A1C, and triglycerides. LDL and HDL showed only numerical improvement. A very interesting finding in our patient was that the fat-free mass had only a numerical decrease without reaching statistical significance. We can conclude in our study that bariatric surgery has demonstrated to be an effective treatment modality for patients with severe obesity and type 2 diabetes. Our findings suggest that at 12 months average, there is a reduction in visceral fat and A1C without significant loss of muscle. We need further prospective studies to better understand these findings. Thank you.